So guys, let's now talk about the brachial plexus. Now this has been and will be one of the very important topic from the upper limb. All the nerves of the upper limb, they originate from the brachial plexus only. So this here we have to understand that how exactly those nerves originate, which part of the brachial plexus gives off those nerves, and ultimately we will talk about some injuries of the brachial plexus and their outcome. Well, brachial plexus, it is mainly found by the ventral primary rami of C5 to T1. Although you may have an inclusion of C4 also on the T2 as well, that can be a prefixed or post-fixed type of brachial plexus. But if we talk generally, the brachial plexus is usually from C5 to T1. So as I said, I should write this as well, that the brachial plexus, it is found by the ventral primary rami. It is by the ventral primary rami of C5 to T1. C5 to T1. Let us understand the formation of the brachial plexus in a schematic diagram, and we will also see that what branches will be coming out of it. When I say C5 to T1, so I guess let's believe this is a C5 here. Here we have C6, the C7, C8, and let's say this is T1. So these are the 5 root value which will contribute to the formation of the plexus. Okay, now what you'll see that C5 and C6 root, they will travel for some distance and they will unite with each other like this. Similarly, C8 and T1 root will also travel for certain distance and they will also unite with each other. And then if I extend this junction of C5 and C6 more laterally into the axilla and toward the arm, and this do the same with the C8 and T1, and let us leave C7 alone for now, just for your understanding only. Let's say this is C7 here, right? So what I'm seeing as of now, that C5, C6 roots are uniting, C8, T1 roots are uniting, and C7 is alone for now. So starting from this very proximal part itself, this portion of brachial plexus still here is called as a root of the brachial plexus. This is called as a root part. These here are the roots. So we call it C5, C6, C7, C8 and T1 root. When these roots, some of them they unite, some of them are not, and ultimately what are they forming is called as a trunk of the brachial plexus. When you look at a tree, we have a root below and then we have a trunk and then we have branches. That's the same way we are going in here. We got a root here and then we have the trunk. So let's say these are 3 trunks which are being formed here. Let me just draw a line to demarcate that. So this portion here is regarded as the trunks of the brachial plexus, and as you can see, we got the upper trunk. Let me write it here. That is upper trunk. This is the middle trunk, and we got this lower trunk. As you can clearly see that upper trunk, if somebody asks you what is the root value for the upper trunk, it's C5, C6 both. Middle trunk is made up of C7 and lower trunk is C8 and T1. And guys, remember we are talking about the trunk, not the cord. So upper, middle and lower trunk. After trunk, there comes a part of brachial plexus where these trunks will contribute to each other. And that's why this portion is called as a divisions. This portion will be called as a division. Like upper trunk will give off like 2 divisions here. Middle trunk will give off 2 divisions. So this is like that dividing and contributing to the other trunks also. So what you'll see, the upper trunk will give off a dorsal division which will go toward the middle. And even lower trunk will give off a dorsal division which will go toward the middle like this. Let me draw these arrows so that it's easier for you to remember. So the middle trunk, which was only made up of C7, at this point I can see that even C5 and C6 can also contribute to it like this. And C8 and T1 can also contribute to it. So suddenly this becomes very rich here. It was only C7 till this point, and from beyond this point it can receive C5, C6, C7, C8, T1. Everything can come into this. So this middle one is receiving the 2 dorsal divisions here. The reason we call it dorsal division because this portion is slightly posteriorly placed. If this portion is slightly posteriorly placed, so these division has to go slightly back to join it. So we call it dorsal divisions. These are the dorsal division. Whereas if this trunk, if middle trunk has to give any division to this one or this one, that division has to come slightly in front, and we call it ventral division. So what happens is the middle one receives from both, from upper and lower, but when at the time comes it to give, the middle trunk only gives it back to the upper trunk and not the lower. Middle trunk is giving a ventral division to the upper one and not to the lower one. So it is receiving from both but giving it back to the upper one only here. This portion of brachial plexus is called as the division part of brachial plexus. This is a division part of brachial plexus, and whatever resultant is now formed here, whatever is now formed, all these are called as the chords of the brachial plexus. These are the chords of the brachial plexus. Now understand this, guys. When you name the chords of the brachial plexus, we name them as lateral chord, posterior chord and medial chord. And why such name is given to them? Because it is based on the relation to the axillary artery. You can call it upper, middle and lower in this schematic diagram, but this is not upper, middle and lower. The upper one is more laterally placed to axillary artery. Middle one is behind the axillary artery, and this one is medial to axillary artery. You don't have to draw this. This is just for your understanding. Imagine if this is axillary artery here. Let's just say, so what you see here, this cord is lateral to axillary artery, this is medial to axillary artery, and that one over there is actually posterior to axillary artery, and that's why the name given to them is a lateral cord, posterior cord and medial cord. Lateral cord, posterior cord and the medial cord. So let me name that for you. This here is the lateral cord. I'm writing LC here, that is lateral cord. This is PC, the posterior cord, and this one here is the medial cord of the brachial plexus. Okay. Now you should also know that this medial cord of the brachial plexus, it gives off a branch which will join with a branch coming from lateral cord, and together they will give rise to a median nerve. Like imagine if this here will continue as a median nerve later on. This, let me just make it a bit thicker here. This median nerve is formed like this. So we have a contribution coming from which cord? Lateral cord. And we also have a contribution coming from the medial cord, and they together give rise to this very, very important nerve. I should name it here only, and this nerve is the median nerve, called as a median nerve. Okay, we'll come to this median nerve later. Now the point is that we have root, trunks, division and chords in the brachial plexus. The first thing to note here is that out of all the four parts of brachial plexus, the one which will not give any branch to muscle or something, that is the division portion. Now this also is one of the question asked in the AIIMS, that which part of the brachial plexus gives no branches, and that is a division. So I'm writing it here. You can write that separately also, guys. The division gives off no branches. We do not have any branch coming to the muscle or something. This is from the division. We have branches coming from root, trunk and chords only. Now from the root, we have mainly two nerves coming out here. From the trunk, we have two nerves coming out here, and majority of the nerves will come out from the chords of the brachial plexus. So what I'm going to do is, let me use a different color and try to mark what nerves will come out from what part, and then we'll discuss them one by one. Now from the root, you will see one nerve will come from C5. I'm using this red color here, guys. This is, let's say, nerve number 1 coming from C5. And you will see a nerve coming from C5, C6 as well as C7 and going down like this. This is nerve number 2. So before we go any further, let us talk about what is this nerve 1 and nerve 2. As you can see, both are coming from the root. One is from C5 and one is from C5, C6 and C7. And as I always say, there is always some sort of logic you can apply. It's not to mug it up. Even when you have to remember that what muscles are supplied by this nerve and this nerve here, you can kind of think about it, that logically what muscle could be there, or is there a way to remember those muscles here? Okay, so I'm just taking you away from this diagram here. Guys, we said first we are talking about what? Branches. From where? We are talking about the branches from roots. Let's talk about the branches from the root. So we gave it number 1. The number 1 we gave it to the nerve called as the dorsal scapular nerve. That nerve is called as a dorsal scapular nerve, which was coming from C5. And the other nerve we talked about there was a long thoracic nerve. Dorsal scapular nerve and long thoracic nerve. Dorsal scapular and long thoracic nerve. Dorsal scapular and long thoracic nerve, see what they're going to supply. And I want you to think about it. Both these nerves are coming from which part of the brachial plexus? Root. If you just imagine, consider on me, Root of the brachial plexus will be somewhere here, close to the midline only. Then there will be the trunk, and division and cords will be more later in the axilla. That means dorsal scapular nerve and long thoracic nerve, which are coming from the root, if they go down, they must be supplying something or the muscles which are close to the midline. And when I say the muscle close to the midline, which border of scapula am I pointing at? Which border of scapula is more toward the midline? It's a medial border of scapula. And this is the catch here, guys. If you think of the muscles which are present along or attached along the medial border of the scapula, all the muscles on the medial border of scapula are supplied by this branches coming from the root. Let's understand it diagrammatically. It's always easy to remember the things diagrammatically. Let us say this here is a scapula. If let's say this is a dorsal view, obviously I'm talking about dorsal scapular nerve. So let's say that's a dorsal view of the scapula, and obviously this border is what? That's a medial border. What muscles are inserted on the medial border? We have a muscle here which is present called as levator scapula inserted here. At the root of the spine we have a rhomboideus minor, and then below the root till the inferior angle we have rhomboideus major. What muscle we said? We said this one here is levator scapula. I'm writing in short. This here is the rhomboideus minor, and here we got rhomboideus major. All three muscles inserted, and all of them are inserted along the medial border. And all these three muscles are supplied by what nerve? They are all supplied by the dorsal scapular nerve. They're all supplied by the dorsal scapular nerve. So it's very easy to remember. The nerve is dorsal scapular nerve, so it is supplying the muscle on which surface? Dorsal surface of scapula. Where? Along the medial border of the scapula. Now, if I look at the costal surface of the scapula, the same thing if I draw it from this side. Let's say, guys, this here is the costal surface. Right now, you're looking at the anterior surface or the costal surface. The only muscle that you will see inserted from top to bottom along the medial border here is serratus anterior. This muscle here is the serratus anterior muscle, and as you can see from the diagram itself, serratus anterior muscle again on the medial border, and that is supplied by the long thoracic nerve. So it is supplied to the long thoracic nerve. Long thoracic nerve, which is also called as the nerve of Bell. It is also called as nerve of Bell. And if in case there is any injury to the long thoracic nerve, in case of injury to the long thoracic nerve, it can lead to the winging of scapula. It can lead to the winging of scapula. Although we usually regard the winging of scapula as due to the injury to long thoracic nerve or the involvement of serratus anterior, but this is not the fact that goes only with the long thoracic nerve. See, any muscle that you see attached along the medial border of the scapula, or the one which keeps the medial border of scapula along its along the rib cage, like the trapezius muscle, like rhomboid muscle, all these muscles, they are also responsible for keeping the medial border of scapula along with the rib cage only. So involvement of even these muscle or trapezius muscle, which is a muscle covering the entire the medial half of the scapula from the posterior side, that can also lead to the winging. So yes, mainly the winging of scapula is because of involvement of long thoracic nerve, but as I said, it is not hard and fast. Like if the spinal accessory nerve in the neck is involved, which involves the trapezius muscle, that can also lead to the partial winging of scapula as well. So this is about the two nerves coming from where? From the root here. That is, one is dorsal scapular nerve and long thoracic nerve. And as I said, what you have to remember, think about the muscle which is attached along the medial border of the scapula on the costal surface and on the dorsal surface. Okay. Now let's go back and look at the other branches. Now after root, we said we got some branches coming from the trunk. Now from the trunk, in the upper, middle and lower trunk, only and only upper trunk gives off the branch. So we have a branch coming from the upper trunk. There are two branches coming from the upper trunk. Let's number them as 3 and 4. So we have the nerve number 3 and 4. Both are coming from the upper trunk. No nerve from the middle and no nerve from the lower trunk here. So let's talk about what are these two nerves. Now we are talking about the branches. From where? From trunks. Well, not trunks, it's just trunk only. Upper trunk is giving the branch. And what nerve we have? We have nerve number 3, which we numbered as 3. That nerve here is called as a suprascapular nerve. That is called as a suprascapular nerve. And there's another one there which is called as the number 4, nerve to subclavius. We got some interesting questions on them as well. Suprascapular nerve and nerve to subclavius. Guys, suprascapular nerve, it supplies the muscle supraspinatus, of course. It supplies the muscle supraspinatus. But you should remember, it also supplies the muscle infraspinatus. Because by looking at the name, the suprascapular nerve, supraspinatus is easy to remember. But infraspinatus is also supplied by the same suprascapular nerve. Both supraspinatus and infraspinatus. One is present above the spine of the scapula, one is below the spine of scapula. Out of the supraspinatus and infraspinatus, you should know that supraspinatus is responsible for 0 to 15 degree of abduction at shoulder. First 15 degree, guys, 0 to 15 degree. First 15 degree of abduction, or you can say the initiation of abduction at the shoulder joint, is the function of the supraspinatus. Now this gives rise to an interesting question here. Now let's say if the question says a patient is having difficulty in abducting the shoulder joint. Now please listen to this question carefully. If you simply say there is a difficulty in abduction at the shoulder, then you will say, okay, it is because of the deltoid muscle involvement which is supplied by axillary nerve. Different story. But if the question specifically mentions that a patient is having difficulty in initiation of abduction or in starting the abduction, then your answer will not be axillary nerve, your answer will be suprascapular nerve. Suprascapular nerve supplies supraspinatus, which is to initiate the abduction movement. So it is important to read the question very carefully. Is it generally about the abduction of the shoulder, or is it about the initiation of abduction at shoulder? And imagine if a person comes to you with a difficulty in initiation of abduction. Now what trick movement they will do to this? Now if you ask them to, let's say if my right supraspinatus muscle is involved and you ask me, okay, abduct the right shoulder. So what I'm going to do is, because I cannot start the abduction movement as my muscle is not working here, I will use my other hand to do the abduction for the initial degrees first, like 15-20 degrees, and then my deltoid muscle will take over. So I need a passive support from the other side to just start the abduction, and then the abduction will begin. Or there could be another trick movement, that if my arm is hanging on the side, and if you ask me to do the abduction in this shoulder, what I can do is I can actually bend onto this side. When I bend to this side, obviously there is some angle created between my body and the arm. And once this angle crosses more than 15 degree or something, that means the action of supraspinatus is taken over. So if you bend to one side and you make an angle of 15 degree or more than that, then your deltoid muscle can do the abduction here. So imagine if you ask me to do the abduction in the right shoulder and my right supraspinatus is not working, what I might do? Either I'll do it like this, or I'll bend to one side and then use the deltoid muscle to do the rest of the abduction here. So that ways you can identify that a person might be having an injury to the suprascapular nerve. The second nerve here in the line is nerve to subclavius. As the name suggests, the nerve to subclavius is going to supply the subclavius muscle. That is nothing, no big deal. It is going to supply the subclavius muscle, fine. But what is important to note from here is the nerve to subclavius, sometimes it gives an additional root value to the phrenic nerve. Now we generally say that phrenic nerve is the root value for the phrenic nerve is C3, C4 and C5. Phrenic nerve supplying the diaphragm, and the root value for the phrenic nerve is C3, C4, C5. But the C5 part of the phrenic nerve, it may arise from the nerve to subclavius and then joins the main phrenic nerve. What I'm saying, guys, is let's say this here is the phrenic nerve which is going to supply the diaphragm. So let's say this is the phrenic nerve which is going to supply the diaphragm. Now you may see a branch coming from the nerve to subclavius and joining the phrenic nerve very much in the upper part itself. So this is basically providing the C5 root value through the phrenic nerve, and this nerve here is called as the accessory phrenic nerve. This is called as the accessory phrenic nerve. So this again could be a very good question here, that accessory phrenic nerve arise from where? Accessory phrenic nerve arise from the nerve to subclavius. Accessory phrenic nerve arise from the nerve to subclavius and then joins the main phrenic nerve only. It's not going to supply the diaphragm separately. It just joins with the phrenic nerve only, giving the C5 root value to the phrenic nerve. So these are the branches from the root and from the trunk of the brachial plexus. As I said, trunk, that means only upper trunk we are talking about here. Then we already said that there are no branches coming from the division. If I go back here, there are no branches coming from the divisions, and then rest of the branches will be coming from the cords here. Now there are loads of branches from the cords, from the lateral cord, posterior cord, and medial cord. Okay, now there's a mnemonic which goes in here, guys. If I talk about the lateral cord first, the branches coming from the lateral cord can be remembered as LML. Then we got a posterior cord. The branches from the posterior cord can be remembered with the mnemonic that is lunar or ulnar, whatever you can remember. You can use it as a lunar or ulnar. And then we got a medial cord of the brachial plexus. The branches from the medial cord, the mnemonic here will be the M4U. So we have a LML, lunar, and M4U. In old time, my professor used to tell me this mnemonic, like a boy on the LML scooter came in the lunar night, that means moon night. M4U. A boy on the LML scooter came in the lunar night and proposed a girl that I am for you. Well, the mnemonic looks more difficult than the branches, so we better stick to this, the smaller versions only, LML, lunar, and M4U. LML. Now I want to clear out one L and one M from here in the picture itself, guys. Now we already said what nerve is formed in here. This nerve here is a median nerve, right? And you already saw that median nerve is formed by the contribution from this cord as well as this cord here. So one L here will be the lateral root of median nerve, and one M here will be the medial root of median nerve. So that's one L from here, and one M for this medial cord here. So remember that. So let me start with the branches coming from the lateral cord of the brachial plexus first. L, M, L. So one L, we already said what was that? That was the lateral root of median nerve. M stands for musculo. It stands for the musculocutaneous nerve. I'll tell you more about this musculocutaneous nerve. And this another L here, it stands for the lateral pectoral nerve. That stands for the lateral pectoral nerve. Well, lateral root of median nerve is just a contribution to the median nerve. What about the remaining two branches? Musculocutaneous nerve. Now look at the two things in this, guys. One is musculo and one is cutaneous. The reason for giving it such name, because this nerve is going to supply the muscles of the anterior compartment of arm, and after that it becomes cutaneous. So what you'll see, this nerve coming from the brachial plexus, it pierces the coracobrachialis muscle, passes deep to the biceps, obviously supplying the biceps as well as brachialis. So that means it is supplying all three muscles of anterior compartment. And then from the roof of the cubital fossa, you will see it is running toward the lateral side of forearm, called as lateral cutaneous nerve of forearm. Let me write that for you. What I'm saying is musculocutaneous nerve, it supplies all the three muscles. We call it BBC muscle. What muscle? That is biceps brachii. It supplies brachialis, and it also supplies the coracobrachialis. So that's what we call it, BBC muscle. BBC, the BBC muscle. All the three muscles of anterior compartment, they are supplied by the musculocutaneous nerve, the biceps brachii, the brachialis. Remember, it's brachialis, guys, not brachioradialis, and coracobrachialis. And after supplying these three muscles, after supplying the BBC, this nerve will continue as lateral cutaneous nerve of forearm. The nerve will continue as the lateral cutaneous nerve of forearm. That's why the name is musculocutaneous nerve. After supplying these three muscles, then it gives off the cutaneous. If somebody asks you that musculocutaneous nerve pierces which muscle, you can note that also. The muscle which is pierced by the musculocutaneous nerve is coracobrachialis. That's how it enters the anterior compartment. Coracobrachialis muscle is here, more toward the medial side. So when the nerve comes from the axilla, it pierces the coracobrachialis and enters the anterior compartment. Then it runs deep to the biceps, superficial to the brachialis, and ultimately as a cutaneous nerve in the forearm. The next one in the line is a lateral pectoral nerve. Now what about lateral pectoral nerve, guys? This is also we've discussed here. Lateral pectoral nerve is the one which was piercing the fascia called as a clavipectoral fascia. clavipectoral fascia. And once it is piercing the clavipectoral fascia, it comes out to supply what muscle? It supplies the muscle that is pectoralis major. It is supplying the muscle pectoralis major after that. It may sometimes supply pectoralis minor also, but usually it supplies pectoralis major only. So lateral pectoral nerve pierces the clavipectoral fascia, comes out and supplies pectoralis major. It's always wise to talk little about these smaller nerves here in the brachial plexus only. Don't wait for the musculocutaneous nerve or the lateral pectoral nerve to come into the respective part here. Because we're discussing brachial plexus, if you read a little bit about these nerves here itself, it will be easy for you to remember that what their function is and what they're going to supply. From the lateral cord, let's now move on to the posterior cord of brachial plexus, guys. The next in the line, we got a posterior cord of brachial plexus. What we said, what are the branches of posterior cord? I said lunar. Do you remember? L-U-N-A-R. These are the 5 branches coming from posterior cord. Where L and U, they stand for the lower and U is for the upper. Lower and upper subscapular nerve. There is a lower subscapular nerve. And this one here is the upper subscapular nerve. Now let me first talk about these two only, guys. Upper subscapular nerve, it supplies the muscle subscapularis, and that's it. It supplies this big muscle, the big medial rotator of that is called as subscapularis. It is supplying the subscapularis muscle. Whereas lower subscapular nerve, it is going to supply the muscle subscapularis again, making it a hybrid muscle. It supplies subscapularis, but along with subscapularis, it also supplies the muscle that is teres major. It also supplies the muscle teres major. So that is the point to be remembered here, that first of all, that subscapularis here is what type of muscle? It's a hybrid muscle. And secondly, teres major is supplied by the lower subscapular nerve. Now you got to keep an eye on the nerve supplied to teres minor and teres major. So teres major is by what? Lower subscapular nerve. Coming to this N. N here stands for the nerve to latissimus dorsi. Nerve to latissimus dorsi, also called as the thoracodorsal nerve. It is also called as the thoracodorsal nerve. Obviously supplying the broadest muscle in the human body, that is the latissimus dorsi. Broadest, not the largest, the broadest muscle, that is latissimus dorsi. A stands for the axillary nerve. Axillary nerve, the one which supplies the deltoid muscle. We know deltoid is responsible for 15 to 90 degree of abduction, that deltoid muscle. And along with the deltoid, it is going to supply the muscle teres minor. And that's what I was talking about, that keep an eye on the teres major and teres minor. Don't confuse them, guys. Teres minor is supplied by the axillary nerve. Teres major is supplied by the lower subscapular nerve. And of course, the R here stands for the radial nerve, and we will talk about the radial nerve in detail separately. We'll discuss the radial nerve at the end, so let's not talk about it. Radial nerve is supplying the all extensor muscles in the arm and forearm. We'll come to that. So these are broadly the branches coming from which cord? The posterior cord. And finally, let's come to the branches from the medial cord of the brachial plexus. The branches from the medial cord of the brachial plexus, and as we use the mnemonic over there, that is M4U. Well, this M4U here means there are 4 M. We got M, M, M and M, and there is a U. M4U. Well, 2 of these M are very easy to remember, because in LML, in the lateral cord, one was the lateral root of median nerve and one was lateral pectoral nerve. Same way, this here is going to be the medial root of median nerve. There is a medial root of median nerve, and this here is a medial pectoral nerve. That's a medial pectoral nerve, and medial pectoral nerve is going to supply the muscle that is pectoralis major as well as pectoralis minor, both, making pectoralis major definitely again a hybrid muscle here. Pectoralis major was already, we said, discussed, supplied by what? It was supplied by the lateral pectoral nerve. Now you're seeing the even medial pectoral nerve, after piercing and supplying the pectoralis minor, it supplies the pectoralis major also. So pectoralis major, just like subscapularis, also is a hybrid muscle. Then we got the two cutaneous nerve with this name M here. One is supplying the skin of the arm here, and one is supplying the skin here. So we have the nerve called as medial cutaneous nerve of arm, and this here would be the medial cutaneous nerve of forearm. So guys, this M here, it is the medial cutaneous nerve of arm, and then we have medial cutaneous nerve of forearm, supplying the skin, medial cutaneous nerve of arm and forearm. And then U stands for the ulnar nerve. Again, we'll discuss this major nerve separately in detail. So U is for the ulnar nerve. So these are the branches coming from the cords of the brachial plexus. 3 branches we saw LML coming from the lateral cord, lunar, the 5 branches we saw coming from the posterior cord, and M4U, 5 branches we saw coming from the medial cord of the brachial plexus. So root gave off the branches, trunk gave off the branches, upper trunk. Division, there were no branches, and there are lot of branches coming from the cords of the brachial plexus. Now, after understanding these, the formation of the brachial plexus and the branches, let us now talk about some point of the brachial plexus which are vulnerable to injury. The trunk, upper trunk and lower trunk of the brachial plexus are vulnerable to injury, and those paralysis or those palsies are called as the Erb's palsy and Klumpke's palsy respectively. So let's talk about the injuries of brachial plexus. Now, before we go into the detail of those injuries, now let me just very quickly again draw this brachial plexus for you. C5, C6, C7, C8 and T1. We don't have to go into too much of detail in drawing it. This was that's how it was, and somewhere here it was the division portion, let's say. Okay, let's keep it simple. Right? Now, obviously, this here is the upper trunk of brachial plexus, and that is the lower trunk of brachial plexus, guys. Upper trunk of brachial plexus, we already saw 2 nerves were coming out of it. One was suprascapular nerve, and one was nerve to subclavius. Now, if you look at this point here, if I just encircle this region, this basically is a meeting point of, you can say there's a point where almost 6 nerves are in there. How come there are 6 nerves? We have a C5 and C6, 2. Then we have 2 branches coming from the trunk, that makes it 4. And then again, this upper trunk is dividing into 2 divisions also, and that makes it 6. So there are 6 nerves which are meeting at this point, and this point here is called as a Erb's point. This point here is called as Erb's point, and injury to this point here will be called as a Erb's palsy. That will be called as a Erb's palsy. It can be because of, if any heavy object is fallen on the shoulder at this point here, that can lead to the Erb's palsy. That means upper trunk along with these branches will be gone. And if there is an injury to this lower trunk of the brachial plexus here, and sometimes to the root also, that will be called as a Klumpke's paralysis. That is a Klumpke's palsy or Klumpke's paralysis. Klumpke's, guys. Erb's and Klumpke's. Klumpke's could be like, if let's say falling from the height. Let's say if somebody is falling from the height, and while falling down, you grab something in the middle. You just try to break your fall. When you try to break your fall, and you just like grab something, some bar or something, and then there is a sudden abduction. There is sudden very strong abduction here, and that will lead to the stretch in the lower part of the axilla here, and which can lead to the stretching or the tearing of this lower trunk here. It could be because of direct injury to the lower part of brachial plexus or the lower trunk of the brachial plexus, or it usually can be a stretching injury. And both Erb's palsy and Klumpke's palsy can be a birth injury also. While the baby is being delivered, there could be injury to the upper or the lower trunk. So whatever the reason may be, the point is that when these injuries are there, what are the most susceptible muscle here, and then what kind of the main clinical feature it will give rise to. So let's take them one by one. So first one here is the Erb's palsy. Now what you see in the Erb's palsy, first of all, what are the root values which are involved? What are the root values which are involved? Guys, the involved root value here, as you can see it's an injury to the upper trunk. So root value involved is the C5 and C6. We know that upper trunk is made up of C5 and C6. Now this C5 and C6, it is present in many nerve. I mean, there's so many nerve which are having C5 and C6 in their root value, and so many muscles also which are being supplied by the C5 and C6. C5 and C6 is present in the axillary nerve, and C5 and C6 is also present in the musculocutaneous nerve as well. In more as well, guys, axillary nerve. The root value for the axillary nerve is C5 and C6 only, whereas musculocutaneous nerve root value is C5, C6 and C7. Now don't be surprised that how come axillary nerve is coming from C5 and C6, because we said axillary nerve is coming from the posterior cord of brachial plexus. Doesn't matter. Even the posterior cord of brachial plexus is receiving the contribution from the upper trunk. Remember, upper trunk and lower trunk are giving the contribution to the middle one. So it is very much possible to have a nerve coming from posterior cord and still not having C7 in it. Very much possible. It might be having the root value coming from above. And that is the case with the axillary nerve. Although it is coming from posterior cord, but there is no C7 in the axillary nerve, it is only C5 and C6. Now, because of the root value involvement is C5 and C6 only, so axillary nerve is totally gone because C5, C6 both are gone here. But in the musculocutaneous nerve, what you see that C7 will be spared. There is no injury to C7. So this is still working. This is still working. Axillary nerve supplies what muscle? The main muscle. Let's talk about only the main muscle, guys. The main muscle supplied by the axillary nerve is deltoid. Yes, it does supply teres minor also, but let's stick to the main one, deltoid. Whereas musculocutaneous nerve, it supplies biceps. It supplies, we already discussed that, supplies brachialis, and we also said it supplies the coracobrachialis. It supplies coracobrachialis. It supplies biceps, brachialis and coracobrachialis. And here is a catch, here is a question also, guys. Deltoid muscle is gone, no question about it. C5, C6 is gone, deltoid is gone. Forget about it. Biceps and brachialis are also involved completely because they are also supplied by the C5 and C6 of musculocutaneous nerve. But the coracobrachialis also receives the contribution from C7. That's the point here. That coracobrachialis is receiving the contribution from C7, and that is why the coracobrachialis muscle can be spared in the Erb's palsy. So if they give you this question and give you the names of the muscle and might ask you that which muscle can be spared or could be spared in the Erb's palsy, and that is coracobrachialis. Although you will say coracobrachialis supplied by musculocutaneous nerve, but musculocutaneous nerve is not only C5, C6, it is having C7 also, and that C7 supplies coracobrachialis. So that muscle can be spared. So the main feature of the brachial plexus injury, Erb's palsy, we have to see it based on the remaining muscles only. Like deltoid, what is the main action of deltoid, guys? The main action of deltoid is abduction. So if the deltoid muscle is gone, so obviously the shoulder will come into what? Adducted position. There will be antagonistic movement. So this will come into adduction. Biceps and brachialis. Now we know biceps and brachialis muscle, they are for flexion of the elbow. So obviously the elbow will go into extension. Moreover, bicep muscle is a very, very strong supinator also. So imagine if one of your supinator muscle is gone, the forearm will go into what? The pronated position. So what you'll see that your shoulder is adducted, your elbow is extended, and your forearm is pronated like this. And that's how we call it what? Policeman tip hand. This is how it, if like policeman is asking for a tip, so we call it a policeman tip deformity or policeman tip hand. Let me write that for you. What I'm saying is that deltoid muscle involvement, that means deltoid is gone. Let me just use this sign for the injury. If deltoid muscle is involved, we have adducted shoulder now. Adducted shoulder. And because of this biceps and brachialis injury, there will be extended forearm. There will be extended forearm and pronated forearm also. Extended and pronated forearm. We have extended forearm and pronated also, because bicep is a strong supinator also. So overall, the combination of all these three movements will lead to the positioning of upper limb in such a way that we call it what? Policeman's tip hand. This is what you call as a policeman's tip hand. There are other different names given to it: policeman tip hand, or waiter's tip hand, or porter's tip hand. They can call it the porter's tip hand. You can even call it the waiter's tip hand. You can also call it the waiter's tip hand. Like somebody is asking for a tip, so they will turn the hand like this and will ask for a tip. So policeman, porter's, or waiter's tip hand. So guys, this is about the Erb's palsy. Injury was to the upper trunk where the 6th nerve meeting point is there. Involvement of the root is C5 and C6. The main muscle which are involved here is deltoid, biceps, and brachialis. And because of the loss of action of deltoid, biceps, and brachialis, we have such a positioning of the upper limb that it looks like the tip hand, the policeman tip hand. The second type of injury that we talked about there was clump case. So let's talk about the clump case palsy. In case of clump case palsy, as we already saw, the injury was to the lower trunk of the brachial plexus. Now, this time in the clump case palsy, what are the root values involved? The root values involved are this time C8 and T1. The root value involved are C8 and T1. Now again, C8 and T1 is present in many nerves. C8 and T1 is present in the median nerve also. It is a major root value for the ulnar nerve also. But what is to be seen, that C8 and T1 via this ulnar nerve and median nerve is mainly going to supply the muscles of the hand. The intrinsic muscles of hand, the lumbricals, the interossei, they're all supplied by C8 and T1 only, whether by median nerve or by ulnar nerve. So as I said, this C8 and T1 is present in where? It is present in the median as well as the ulnar nerve. Now you'll say it is present in radial nerve also, but the C8 and T1 of radial nerve is not going to supply the muscles in hand. We are looking at the hand muscles as of now, intrinsic muscle of hand. And via this median nerve and ulnar nerve, this C8 and T1 is going to supply the intrinsic muscles of hand. And as I already said, intrinsic muscle of hand refers to the lumbricals and the interossei, mainly the lumbricals and the interossei. The intrinsic muscle of hand are involved. So what will it lead to, guys? See, palmar interossei, dorsal interossei, and lumbricals, when we talk about their function, yes, they do have a different function, like palmar interossei is for adduction, dorsal interossei is for abduction. But there is something common about all the three muscles. There is something which is done by the lumbricals also, palmar interossei also, and dorsal interossei also. So there is one movement which can be done by all three, and that movement is this. Now if you look at my positioning of the fingers here, what joint position I am in right now? Now metacarpophalangeal joint, this one here is flexed. So there is a flexion of metacarpophalangeal joint, and the extension of interphalangeal joint is done by lumbricals as well as interossei. It is done by both. The muscles are placed in such a way, we will discuss that in the intrinsic muscle part. But as of now, remember that the function of the lumbricals and interossei is to cause flexion at metacarpophalangeal joint and extension at the interphalangeal joint. Now, if this was a function done by the lumbricals and interossei, and imagine the nerve supplying them is gone, ulnar nerve is gone, and median nerve is also involved. So because of that C8 and T1 involvement, there will be antagonistic movement in there. So this flexed metacarpophalangeal joint will become extended. In fact, it becomes hyperextended. So there is a hyperextension there. Whereas the extended interphalangeal joint will become flexed like this. And that's why it leads to what? It leads to the claw hand. Because it is an exact opposite of this movement which is done by the lumbricals and interossei. Flexion becomes extension, and extension becomes flexion in the interphalangeal joint, and that is what you call as claw hand. So because of the intrinsic muscle of the hand involvement, there will be hyperextension at MCP, at metacarpophalangeal joint, and flexion at interphalangeal joints. Flexion at interphalangeal joint, and that is what you call as the claw hand. That is what you call as the claw hand. So claw hand is the main feature in the clump-case fallacy. But I'm sure you also must have read one more thing apart from claw hand, that in case of clump-case fallacy, the patient may also have a Horner syndrome. Now, what is Horner syndrome? Horner syndrome is a sympathetic loss on the face. Then you see this ipsilateral sympathetic loss on the face. There will be enophthalamus, there will be anhidrosis, like the meiosis, loss of ciliospinal reflex. So those, all the typical feature of the Horner syndrome that we'll talk about in the head and neck part, can also be because of the clump-case fallacy. Now, why is it so? Because in this case, the injury, the root involvement was C8 and T1. T1. And T1 is the first sympathetic nerve, guys. The T1 sympathetic nerve will use the sympathetic chain, will go higher in the sympathetic chain, and will come out and supply the face. Sympathetic outflow, the sympathetic outflow that we talk about is thoracolumbar outflow. And because it's a thoracolumbar outflow, the first sympathetic nerve comes from T1 only. Now that sympathetic nerve, the preganglionic sympathetic nerve, goes into the sympathetic chain. It ascends in the sympathetic chain and comes out from superior cervical ganglion to supply the ipsilateral smooth muscle on the face. So, because of the T1 involvement, in clump-case fallacy, it can also lead to the Horner's syndrome. We discuss Horner syndrome more in the head and neck and the neuroanatomy part. So that Horner syndrome, in which we see the ipsilateral sympathetic loss on the face, can also be in case of the clump-case fallacy because of the involvement of the first sympathetic root outlet, that is T1. So claw hand, or maybe, and Horner syndrome, it's like maybe, will be seen in case of the clump-case fallacy. So guys, this is all about the brachial plexus, the formation of the brachial plexus, the branches coming out of the brachial plexus. Except the division part, there were no branches. And then about some important fact about that, which muscle the major nerves are being supplying here, and the injuries of the brachial plexus as well.